Well, we're going to move to the next presentation. The title is in reverse, TAP versus DK crash for bifurcations, interim analysis of the rTPA trial. And the speaker is Ioannis Tsiafoutis from Greece.
Thank you very much, dear Chairman, dear colleagues. It's an honor and a privilege to participate in this high-level session. And next minutes, I'm going to present to you the reverse TAP technique versus DK crash for coronary bifurcation, the interim analysis. I do not have any potential conflict of interest while the study. These bifurcation lesions are approximately 15 to 20% of PCIs, and in up to 30% of these procedures, a two-stent approach is required. Many techniques have been proposed. The double kissing crash technique is an established approach as has showed better outcomes comparing to provisional stenting and Quillot technique in the DK crash trials. We have recently described and shown 2 years ago here in EuroPCR the modification of the TAP technique, the reverse T-stenting and small protrusion technique. The rTAP trial is a randomized multi-center clinical trial designed to compare the rTAP with the DK crash technique. This is how our technique comes. First step is pre-dilatation, depends on the operator's choice. Second step, we position the side branch stent mini protruded into the main vessel and at the same time main vessel balloon. Inflate the stent and balloon simultaneously, do first kissing. Then the fourth step, we pull back half of the balloon of the side branch stent into the main vessel and do kissing again so that the stent of the side branch not be crushed. Then remove the side branch, position and deflate the main vessel stent, and the final step, require side branch and do final kissing. This is a video of our technique. First step, predilation. After that, we position the side branch stent, mini protruded and main vessel balloon also. Inflate both balloon and stent. Pull back half of the balloon of side branch stent to the main vessel and do kissing again. Then remove the wire and position and deflate main vessel stent. Rewire both and do kissing. And this is the final result. What are the advantages of this technique? It's simple and quick. It eliminates possibility of protruding struts into the main vessel. There was no jailed wire. We can use two-stent bifurcation lesion with a 6-French catheter. It's easily positioning stents. We have no way to pass through struts the side branch stent. And the plan of the main idea of this technique is first stenting the side branch, fully covering the ostium, and then stenting the main vessel. And this is a model from bench testing that we have manufactured. What did we study? Patients with bifurcation lesions, true bifurcation lesions, amenable to PCI with two stents, are randomly assigned to a rTAP or DK crash procedure. Clinical follow-up visits are performed at 1, 6, 8, and 12 months. Follow-up coronary angiography is performed at 8 months after the index procedure. The primary endpoint is restenosis at the side branch at 8 months, and the secondary endpoints are total and net fluoroscopy in procedural time. By the word net, we mean the time from engagement of guide cath to final kissing balloon, and the occurrence of major adverse cardiac events at 12 months, including cardiac death, myocardial infarction, or target vascular vascularization. During a period of 10 months, 32 patients have been enrolled, 17 patients in the rTAP group and 15 patients in the DK group. Of total sample size of 136 patients are required. The patient characteristics clinical characteristics are equal for the two groups, and the angiographic characteristics also, with a big difference in the total number of balloons used. That is the first sign of less complexity in our technique. What are the essential results? The MACE are equal with one emergency coronary artery bypass graft for a patient in the DK crash group. We have same late lumen loss for the main vessel and the side branch as well. Total and net procedural time, as well as total and net fluoroscopy time, were lower in the reverse TAP group, albeit the differences were not statistically significant. This is the graphic that shows that. We see in the first graphic, the net fluoroscopy time, there is the bigger difference with a p-value about 0.05. Initial results of the TAP trial suggest that the technique is equally effective with the DK crash, with a trend for lower procedural and fluoroscopy times. Statistical significance may be accomplished after the final enrollment of acquired sample of size of patients. Conclusively, these are the first results of the rTAP trial comparing the reverse TAP technique with the decay crash technique for bifurcation lesions. Less time and less complexity for our technique with no differences in initial radiographic results in follow-up at 8 months suggests that might be equally effective and simpler in selected patients that need two-stent technique. Waiting for final results after enrollment of the estimated sample size. Thank you very much.
Thank you very much. I will ask Dr. De Palma to discuss this presentation.
Thanks very much for the presentation. You obviously haven't completed the study yet, so there are too few data points to draw too many conclusions. But just remind me, the primary endpoint was what exactly?
Stenosis at the side branch.
And in terms of the experience of the operators, particularly for the DK crush technique?
They are high volume operators. I forgot the acknowledgement to all my colleagues. Here's the operators that are all high volume operators with good many procedures with the DK crush.
Okay, so they're experienced at doing it.
Yeah, good experience.
And the antiplatelet strategy?
It depends on the operator's choice every time.
Okay. And what made you choose this kind of reverse tap if you're experienced at DK crush?
What
gave you the idea to do the study?
It gave me the idea because I did that once just by chance on a patient, and I saw that was very simple and had excellent results. I have done a series of patients with IVOS also, and they were going fine. So I tried that, and I saw that it works, and we could check it better.
And the step that you're missing out is the pot. Is that correct?
Yeah, there's no pot, but there is a step that makes difference from crushing the stent. It's a point that you pull back half of the balloon of the side branch and inflate it with kissing, and then you create maybe a new carina that depends on the angle of the side branch.
Thanks. Just one question. According to the angle of the bifurcation, yes, is there any limits for the technique?
Yeah, I think that when the angle is less than 60 degrees, I think 60 degrees, I think that maybe you're going to have a mini crash. That's
30 degrees is the limit?
Yeah.
For you? The fact that you create a neocarina, we miss maybe some imaging in that study to show how much protrusion do you have in this neocarina.
We tried that. If you saw the bench model, here it is. It's I think it shows well how it goes. But then we have done also IVUS, and we're gonna have OCT step by step in next procedures to have an imaging step by step of our stents of our patients.
In your experience, maybe it's longer than this trial. Did you observe stent thrombosis with that?
No, we did not have.
Is there any different behavior? Anything to worry about?
Actually, we didn't have any event concerning us.
Can you tell us, maybe I've missed it, how many patients do you want to include, and what is the sample size calculation for the entire study?
136 is the sample size.
But then you need to assume a huge difference in side branch restenosis with such a low sample size.
Yeah, that's what we're trying to have.
Mm-hmm.
Okay, thank you very much.